Good morning, students. Today we will see the final year BSc Nursing Supplementary Examination June 2015, Obstetrical and Gynecological Nursing. So the first question was explain the physiological changes that taking place in reproductive and endocrine system during pregnancy. That carries 8 marks. And the second question, the second part of the same question, discuss the nursing management of a pregnant woman during the third trimester. We will see how it will be written. Physiological changes taking place in the reproductive and endocrine system during pregnancy. First, we will see the reproductive system. The uterus have the muscle layers, endometrium surnamed as decidua, thicker and more vascular fundus. It is the usual site of implantation. Myometrium have 3 layers. That is the outer longitudinal, middle layer is strongest, arranged in a crisscross fashion, and inner circular layer. And the third and the outermost layer is perimetrium, that is a continuation of the peritoneum. Weight of the uterus increased from 60 gram to 1 kg, and size is increased to 7.5 into 5 into 2.5 centimeter into 30 into 23 into 20 centimeters. The painless irregular contraction, that is the Braxton Hicks contraction, starts from 16th week onwards, and the change in the uterine shape at 12th week. Uterus comes out of the pelvis 16th week. Uterus midway between symphysis pubis and umbilicus 24th week at umbilicus. 28th week midway between siphisternum and the umbilicus. 36th week at siphisternum. 40th week forefinger bed below siphisternum because of the lightening occurs. Blood supply to the uterus increases to meet the need of the growing fetus. Hagar sign, Osiander sign, Chadwick signs, Giacomo sign, Goodell sign. Cervix secretions become copious due to the effect of progesterone. The length of cervix remain unaltered. The endocrine system, pituitary gland, FSH and LH stop, growth hormone increases, serum prolactin produced by anti-pituitary increase by 10 times. At term, posterior pituitary gland produce oxytocin. SCH and CRH will be increased. Thyroid and parathyroid gland enlarges at BMR too because of increase in BMR. Early pregnancy T4 increases, TSH remain the same. Parathyroid gland increase in size as the calcium increase in calcium metabolism. And the second part of the same question was nursing management in a pregnant woman in the third trimester. So minimizing fatigue. Teach the woman the reasons for fatigue, plan for a schedule for the adequate rest. Fatigue in third trimester is mainly due to carrying increased weight of the pregnancy. About 8 hours rest needed. Inability to sleep may lead to excessive fatigue during the day. In later months of pregnancy, sleeping on the side with a small pillow under the abdomen may enhance comfort. Frequent, that is 15 to 30 minutes rest period during the daytime is important to avoid over fatigue. Whenever possible, her work should be done while sitting, held with the legs elevated. Women should avoid standing for a prolonged period, especially during the third trimester. Promote placental perfusion. The woman should not lie flat on her back. Left lateral position provide the best placental perfusion. However, either side is acceptable. Reducing anxiety and fear, and promoting preparation for labor, delivery, and parenthood. Encourage women or couple to discuss their knowledge, perceptions, cultural values, and expectations of labor and delivery process. Provide information on childbirth education classes and encourage them to attend. Provide information on sibling and grandparent preparation as indicated. Encourage a tour of birth facility. Discuss coping and pain control techniques for labor and birth. Inform the woman or the couple of common procedures during labor and birth. Provide guidelines for coming to the birth facility or the labor room. Encourage women or couple to discuss their perceptions to idealize child. Discuss infant sleeping, eating, activity, and response patterns for the first month of their life. Discuss physical preparation for the infants, their sleeping pace, clothing, feeding. Discuss plans for returning work and childcare arrangement. Discuss the importance of planning time for themselves for each other, apart from the neonate. Providing information to encourage attendance at the baby care, breastfeeding, and parenting classes. Answer any question the woman or the couple may have. Altered urinary elimination related to uterine enlargement, increased abdominal pressure, fluctuation of renal blood flow, and GFR. Objectives include verbalize the understanding of the condition, identify ways to prevent urinary stasis, provide information regarding urinary changes associated with late pregnancy, and encourage the client to assume left lateral position. Advise the client to avoid long periods of upright or supine position. Provide information regarding need for the fluid intake 6 to 8 glasses per day. Reduction of intake of 2 to 3 hours before going to sleep. Assess the signs for any UTI. Sleep pattern disturbance related to change in the level of activity. Report improvement in the sleep. Review normal sleep requirement changes, evaluate level of fatigue, advise the client to avoid intake of fluid 2 to 3 hours before going to sleep, not the report of positional breathing difficulties, psychological support to the client to remove fear and anxiety to the client. Constipation related to smooth muscle relaxation and back pain related to the change in the center of gravity due to uterine enlargement, anxiety related to the unknown outcome of the pregnancy, impaired gas exchange related to the uterine enlargement leading to displacement of diaphragm. Knowledge deficit may be related to the childbirth, warning signs to be reported, nutrition, newborn care, fetal monitoring, and risk for altered nutrition less than body requirement related to inadequate intake of food, high risk for maternal injury related to prolonged labor and rupture of membrane, high risk for fetal injury related to maternal health problems, high risk for cardiac decompensation related to the increased demand changes in the preload as a physiological change in the late pregnancy. The second question is define prematurity. Explain the physiological characteristic of a preterm infant. Explain the management of preterm neonate for the first 24 hours after delivery. Prematurity is the baby born before 37 completed weeks of gestation, counting from the first day of last menstrual period. The following are the most common characteristics of a premature baby. However, each baby may show different characteristics of condition. It includes small baby, often weighing less than 2.5 kg, with disproportionately large head, sutures widely separated, and fontanelles are large, small chin, protruding eyes due to shallow orbits and absence of buccal pad of fat. Thin, shiny, pink or red skin, able to see the veins. Little scalp hair. Hair may appear woolly and fuzzy and individual hair fibers can be separated. But fine hair that is covering much of the body. Lanigo. Weak cry and body tone. Sharpened looking, less rounded features than a full-term baby's features due to lack of fat store. Low body temperature, especially immediately after birth in the delivery room due to lack of stored body fat. Labored breathing or respiratory distress, lack of reflexes for sucking and swallowing leading to feeding difficulties. Immaturity of central nervous system is expressed inactivity of and lethargy, poor cough reflex and incoordinated sucking and swallowing. Optic nerve is unmyelinated but presence of papillary membrane makes its visualization difficult. Ear cartilage deficient or absent with poor recoil. Deep salt creases are often not present. In male, testes are undescended and scrotum is poorly developed. In female infants, labia majora is widely separated, exposing labia minora and hypertrophied clitoris. Blood urine nitrogen is high due to low glomerular filtration rate. Renal tubular ammonia mechanism is poorly developed, thus acidosis occur rarely. They are vulnerable to develop late metabolic acidosis, especially when fed with a high protein milk formula. Concentration of urine is poor. Preterm has to have passed 4 to 5 ml of urine excrete 1 millimole solid baby gets dehydrated. The solid retention and low sodium proteins explain occurrence of edema in preterm babies. Explain the management of preterm neonates for the first 24 hours after delivery. The early cord clamping, upgas scoring, drying and keeping under radiant warmer, assessing the respiratory status, provide care accordingly, maintain patent airway, suction is needed, use 2% suction technique, avoid neck hyperextension. Terminate suctioning immediately if bradycardia, hypotensive, cyanotic, mottled or develops pallor. Manually bag until the patient is stable. Position the infant in a sideline or prone position. Frequently change the infant's position. If the baby needs to lay supine, place one small roll under the shoulders to straighten the airway. Elevate the edge with the head and turn the infant's head to the side. Normal apnea, that is periodic breathing 5 to 10 seconds without bradycardia or color change, followed by 10 to 15 seconds of compensatory rapid respiration. Apneic spells cessation of breathing for more than 20 seconds or for less than 20 seconds when accompanied by cyanosis or bradycardia. Meaning oxygenation status. The need for oxygenation administration is determined by signs and symptoms of respiratory distress, PO2, means arterial oxygen pressure or less than 60 millimeter of Hg and means saturation less than 92%. Oxygen is administered by hood, nasal cannula, positive pressure mask or endotracheal tube. Oxygen should not be free flowing in the incubator because amount cannot be controlled. Oxygen needs to be warm and humidified and prevent cold stress and moisten the airway. Feed the baby as tolerated by breastfeeding, extra plus milk formula feed via orally or NG tube. And the third question is obstetric indications of dosage and obstetric indication, dosage and action of prostaglandin. Prostaglandins increase biosynthesis of prostaglandins E and F series in the uterus is a prerequisite for labor and both term and preterm. Prostaglandins are para-autocrine hormones. They already act on locally at the site of production. Half-life is around 1 to 2 minutes. Decidua is the main source of PGE2 alpha. Fetal membrane or amnion produce PGE2 and myometrium mainly produce PGE2. In vivo, PGE2 of alpha promotes myometrial contractility. PGE2 induces the labor with cervical effacement and dilatation. It shortens induction to delivery interval. PGs promote myometrial contraction irrespective of duration of gestation, whereas oxytocin acts predominantly on the uterus in the term or in labor. This has helped widespread use of PGs to avoid first trimester medical termination of pregnancy and also induction of labor at term. Side effect of PGs are less when used vaginally. Local application of PGE2 gel is the gold standard for cervical ripening. Mechanism of action: both PGE2 and PGF2 alpha got oxytoxic effect on pregnant uterus when used appropriate dose. Probable mechanism of action: change in the myometrial cell membrane permeability and alteration in the bound's calcium plus. PGs also sensitize myometrium to oxytocin. PGE2 is 5 times more potent than PGF2 alpha. PGF2 alpha acts predominantly on the myometrium, while PGE2 acts mainly on cervix due to its collagenollytic property. PGE2 causes dissolution collagen bundles and increased submucosal water content of the cervix. Indications: for the induction of abortion in the second trimester, expression of hydrotidipore mode; for induction of labor in IUCD, intrauterine death, augmentation of acceleration of labor, to stop bleeding from open uterine sinuses or cervical priming. Contraindications are hypersensitivity, uterine fibrosis, cervical stenosis, pelvic inflammatory disease, and respiratory disease. PGE2 is widely given as a vaginal tablet, 3 mg dinoprostone in posterior fornix, followed by 3 mg after 6 to 8 hours, maximum 6 mg vaginal pessary, releasing dinoprostone approximately 10 mg over given 24 hours. It is removed when cervical ripening is advocated. PGE2 gel cervical canal below the level of internal os or 1 to 2 mg in the posterior fornix. Parenteral IV prostin E2 containing 1 mg per ml or PGF2 alpha, prostin F2 alpha containing 5 mg per ml or medial analog that PGE2 carbapenem containing 250 microgram per ml. Oral misoprostol can be used when convenient to the patient. It gives 25 to 50 microgram every 3 to 6 hours by oral or vaginal route. Low dose of PGE1 dissolving to PGE1 also is safe. It is repeated at interval of 2 hours. The fourth question was menopause. Menopause is a permanent cessation of menstruation at the end of reproductive life due to loss of ovarian follicle. So phase of menopause are premenopause, perimenopause, menopause, and postmenopausal. There are physiological changes occur in the genital organs, vulva, breast, hair, voice, vasomotor system. Psychological changes and social changes. Then diagnosis of menopause and treatment, that means include non-hormonal treatment and hormonal treatment. This complete this answer. Then, fifth, breast complications in puerperium. The common breast complications in puerperium are breast engorgement, cracked and retracted nipple, mastitis, and breast abscess, lactation failure. Means you have to write in detail about these four. Then cord prolapse definition, types, etiology, diagnosis, management, complications. The seventh question was fetal circulation definition, placenta role in fetal circulation, blood vessels involved in the fetal circulation, shunts involved in the fetal circulation, steps. There are 7 steps of fetal circulation has to be written. Give reasons. Glucose tolerance test to be done routinely for the pregnant woman at 24 weeks of gestation, because glucose tolerance test is become as the urine test for glucose is not reliable during pregnancy when renal threshold for glucose is increased. It is not increased, it is decreased, and the glucose found in the urine of a pregnant woman. Second question, vacuum extraction is contraindicated in the preterm baby because of the fragile cranial bones. It may lead to cerebral trauma, can occur tentorial tear. You immediately after delivery, fundus of the uterus has to massage to make it hard and to prevent postpartum hemorrhage. Methotrexate uses in case of unruptured ectopic with omega strings antimetabolite which act on rapidly dividing cells like embryo. So it will be hinder the growth of the embryo, and so rupture of uterus means tubes can be prevented. Macrosomia is a common complication of gestational diabetes. It leads maternal hyperglycemia will lead to hypertrophy and hyperplasia of islets of Langerhans of fetus. It will lead to increased secretion of fetal insulin, stimulate carbohydrate utilization, accumulation of fat. And second reason, insulin acts as a growth factor. And third one, elevated maternal free fatty acids in GDM lead to increased transport to the fetus, and acceleration of triglyceride lead to adiposity. Differentiate. First one is constriction ring and contraction ring. Constriction ring, otherwise also known as Bandel's ring, or this pathological retraction ring. And second is the constriction ring, a band of contraction. It's an abnormal junction between two segments of uterus, which is a light sign of with obstructed labor. Constriction ring is a band of contracted uterine muscle that forms a stricture around the part of fetus during labor, usually after premature rupture of membrane and sometimes impending labor. The uterine wall is thickened. Second is the difference between placenta, upper placenta previa and upper placenta. The difference are in case of onset, bleeding, pain and uterine tenderness, fetal mass, heart tone, presenting part and presence of shock. Third is the difference between cephal hematoma and Cadbury succerinum. The difference comes in the definition, extent of involvement, causes, period of absorption and treatment. Then sixth, the retroversion and inversion. Retroversion is either congenital or acquired, considered as a normal variant of uterine position, but inversion is extremely rare, life-threatening complication of third stage of labor, where the uterus becomes torn inside out and the fundus prolapsing to the cervix. It may be first degree, second degree, and third degree. The etiology include it comes either spontaneous or iatrogenic. And the 17th question is spontaneous abortion, missed abortion. Spontaneous abortion is involuntary loss of a product of conception prior to 20th week of gestation, and fetus is not capable of independent survival. And missed abortion is one of the spontaneous abortion when the fetus dead and retained inside the uterus for a variable period of time. It is known as carneous mole or bloody mole, fleshy mole. Clinical features are persistence of brownish discharge, subsidence of pregnancy symptoms, retrogression of breast changes, cessation of uterine growth, and no FHS. Thank you. Thank you for listening.